introduction. In the next 15 minutes, I'm going to talk on insulin initiation and intensification in type 2 diabetes. As we all know, one of the biggest challenges in the treatment of type 2 diabetes is initiation of insulin as well as intensification of insulin. And we all know that almost 90% of our diabetic population are treated by either primary care physicians or general physicians, and hardly 10% of them have access to a specialist for intensification of insulin therapy. As you can see from this slide, probably this is how we have been treating our diabetics all these years. We usually follow what is so-called outdated step care therapy. We start the patient on a single drug, go for combination, and by the time we even think of insulin, it is almost a few years gone by and the patient has already developed complications and it is too late. I think this scenario should change, and we have seen that in India, insulin therapy is initiated only when the HbA1c levels deteriorate to more than 9, and the failure to advance therapy when recommended may delay in insulin therapy up to 8 years in many of these patients. And many of the practitioners depend on guidelines issued by various international organizations on when to start insulin and how to start insulin. What I have done is I have taken two. So let us see what the international guidelines say. I have just taken two of the guidelines which are commonly referred to by practitioners. As you all know, the IDF guideline is one of the most useful guidelines for developing countries, which includes many of the drugs that we take. But as you can see here, even this guideline doesn't say how long you have to put the patient on metformin, how long you have to wait. Only thing it says is you have to have a HbA1c of less than 7, and metformin is the first drug. Second, you add a sulfonylurea or other drugs, and the use of insulin comes only as a third line. And the general option given is either you use a basal insulin or a premixed insulin for initiation of insulin therapy. Let us see what the ADH and the ADA and EASD guidelines say. This guideline is more useful guideline, I would say. See, as you can see from here, metformin, they have given a period of 3 months. You try on lifestyle modification in metformin for 3 months, and you can, as a second line drug, they have given the choice open to the physician. You can choose from any of this, and you can see insulin is also there as a second line drug in this guideline. But this guideline says usually we use basal insulin as an initiating drug when you initiate insulin therapy. Now, I will show some of the evidence that whether this guideline is useful in our setup where we have a high problem of postprandial hyperglycemia, whether this guideline-based treatment of starting basal insulin as a first-line therapy is suitable for the Indian population. So please remember, when you decide, finally you have decided to start insulin, there are only two options. Either you start with the basal insulin or you start with the premixed insulin. There are only two options available. So the question is which option to choose in our setup. As you can see in this slide, the premixed regimen, there are two regimens which are compared. These are insulin naive patients where insulin has been initiated in two groups of patients. One group of patient with premixed insulin, that is the orange color lines, and another group of patient with insulin glargine, and patient is already on metformin in both the groups. And you can see glargine given as a bedtime insulin beautifully reduces the fasting blood glucose. The fasting blood glucose comes down very nicely. But if you look at the postprandial blood glucose levels, there is a postprandial blood glucose which is not controlled when you use glargine as monotherapy as an initiating drug. Whereas if you look at the premixed insulin, you start, the fasting may not be controlled to as much as glargine, but still if you look at the postprandial surges are well controlled with premixed insulin. And if you look at the results of this study, the higher percentage of patients treated with premix attained treatment targets except fasting. The same thing which I had shown as a chart where you can see fasting blood glucose alone may be controlled well with premixed with basal insulin, glargine, whereas premixed insulin controls both postprandial. And if you look at finally the HbA1c values which we are interested, you get a better HbA1c result with a premixed insulin rather than a basal insulin. This is again to show the overall hypoglycemia. As expected, with the premixed insulin, we have a little more hypoglycemia, but nocturnal hypoglycemia may be seen more with glargine given at bedtime. Though glargine is said to be a basal insulin, it has a small peak which may happen early in the morning or night and cause hypoglycemia. Then let us look at the few other studies to see whether the durability of this regimen, for how long these regimens are going to be useful. The durability study, where two arms of the study, whether in one arm there is a premixed insulin of 75-25, the other arm there is glargine. Let us see the results. The results show that median time of maintaining A1C goal was 16.8 months for premix, whereas 14.1 for glargine. Patients with lower baseline A1C levels were more likely to maintain the goal, supporting the idea of early insulin therapy. There was no difference in the incidence of hypoglycemia and more weight gain with 25-75 compared with glargine. In addition, patients with higher baseline postprandial glucose and lower 1,5-anhydroglycitol, which shows glycemic variability, were less likely to maintain the goal with basal added to OAD compared to premixed 25-75 insulin. What is this in our context is, let us look at the food habits in India. Cereals are staple diet, carbohydrates form bulk of our meal, and over the years, over the past 3 decades, the intake of carbohydrate has almost remained the same consistently. Though we talk of low carbohydrate diet and increased fiber diet, still our carbohydrate intake forms about 60 to 17% in the Indian population. So it is unlikely that total carbohydrate content of Indians can be altered. To alter our diet, food habit may not be that easy. But of course there are new foods which are coming with high fiber foods, like high fiber rice and other things which prevents the postprandial surge. However, it's difficult to identify such low GI foods generally in the market, and we do have to depend on drugs. So is premix 50-50, which has a higher short-acting insulin, going to be better useful in this population? Let us see. As you can see, this study where they have, with patients with postprandial hyperglycemia, they have shown glargine, NPH twice a day, premixed insulin 25-75 and 50-50, and they have shown the area under the curve. This study has shown the area under the curve, which shows the glycemic excursion is lowest with 50-50, showing that 50-50 insulin may be a useful insulin in setup where postprandial hyperglycemia is high, where intake of carbohydrate as a basic food is very high, particularly in the South Indian population. Then comparing insulin 50-50 with basal bolus, there is another study. Basal bolus, we all know, is a gold standard. It's one of the best, most physiological insulin regimen. And this study shows that if you use premixed insulin 50-50 twice or even 3 times a day before each meal, it is as good as basal bolus. The usefulness of this I will come to a little later. This is again to show that HbA1c levels are almost constant, and this insulin guidelines we would have seen a few years back. These insulin guidelines were issued where consensus from various diabetologists across the country and was taken, and it was shown they all preferred to have premixed as a initiating insulin rather than a basal insulin to control postprandial hyperglycemia. Now look at some. When in the arm of glargine as a initiating dose, what it was suggested is, when you want to intensify your glargine regimen, you add 1 prandial short-acting insulin is the recommendation. Now let us see if that adding 1 postprandial short-acting insulin to glargine is equal or better than a premixed insulin. This is an international study to compare the efficacy of 2 insulin intensification strategies. One is to intensify glargine by adding a short-acting insulin. Another is by increasing the dose of a premixed insulin. So there are 2 arms. Here we have twice daily premixed insulin. Here once daily basal glargine plus 1 prandial insulin, probably given in the morning, which has a highest excursion. The baseline characteristics of both the group are same, and as you can see, it shows that there was significant reduction in HbA1c treatment in both arms. Both arms were almost good. Only the HbA1c values were slightly better in the premixed arm when compared to the glargine plus insulin lispro arm. The percentage of patients achieving HbA1c targets of less than 7 at 12 or 24 weeks did not differ significantly, but there was a slight edge to the premixed arm. Coming to the reported hypoglycemia, it is said that premixed insulin scores more hypoglycemia, and that is why basal insulin initiation is better, but it may always not be true. As you can see in this study, though there were 2 severe hypoglycemias with premixed insulin, but neither of these 2 patients required treatment discontinuation, but otherwise the hypoglycemic episodes were almost similar. The same study was done in the Indian population by Dr. Prasanna Kumar and a large group of other international faculties, and they showed that when they did a study with patients, 40 patients in 2 arms, one with premixed insulin, another with insulin glargine plus 1 lispro, where this again to show the baseline characteristics of the patients were same, and it was seen that glycemic control was almost uniform whether you use a premixed insulin or a glargine plus a single short-acting insulin. Both are equally good in reducing the HbA1c. But there are slight advantages with the premixed insulin, which I will come to a little later. Again here, even in the Indian study, hypoglycemia was almost similar in both the groups, but as expected, the premixed insulin users had slightly more hypoglycemia. Here one patient had severe hypoglycemia, but again that patient did not require stopping of insulin, only the titration of a dose of insulin was required in that patient. So the conclusion from this study was there is little head-to-head data comparing premixed insulin analogs with addition of prandial insulin to basal insulin. In our setup, these 2 studies are classical studies. Intensification with either premixed insulin or insulin plus 1 glargine helps in controlling the blood glucose almost to the same level, but further studies may be required to interpret the best regimen specific for any population or country. Now, finally, I would like to say that in patients with type 2 diabetes, twice daily regimen of insulin mixtures provides similar glycemic control as intense regimen of multiple daily initiations. See, when you initiate insulin, premixed insulins are better than using basal insulin because we cover the postprandial hyperglycemia also. But when we intensify either a basal regimen or a premixed regimen, it also almost comes to the same. But the biggest advantage is by combining the insulin themselves, patients can encounter problems. If you have a basal insulin plus a short-acting insulin separately, he has to use 2 syringes or he has to mix and take, the other problems are there. Whereas if you intensify with a single insulin, that's a premixed insulin, it comes as a single pen or a single vial where mixing is not there, or 2 different insulins are not there to cause confusion. The same insulin the patient takes in the morning, the same insulin patient takes in the night or even in the afternoon. So initiation is easy with the premixed insulin, up titration is easy. Probably we have to be little careful in up titration to prevent hypoglycemia in between meals. So the benefits of premixed insulin formulations include reduced errors and improved dose accuracy as well as convenience of using a single injection. So finally, ladies and gentlemen, I would like to say in the Indian population where postprandial hyperglycemia is a significant problem, at least I would say in the southern part of the country where rice eaters are there, where postprandial hyperglycemia is more a problem, premixed insulin analogs provide quick absorption and rapid postprandial lowering as well as early control of HbA1c and improve control rather than initiating with the basal insulin. I am not saying basal insulin is bad, but if you want to get a quick control, probably the best insulin would be a premixed insulin twice a day. Thank you.